Deep vein thrombosis, DVT, is a serious condition characterized by the formation of a blood clot in a deep vein, typically in the lower extremities. It can lead to significant complications, including pulmonary embolism, PE, if the clot dislodges and travels to the lungs. Etiology and risk factors. DVT results from the interplay of three primary factors known as the Virchow triad: hypercoagulability, endothelial damage, and venous stasis. Common risk factors are divided into transient, e.g. surgery, immobilization, pregnancy, and chronic, e.g. age, cancer, hereditary thrombophilia. Clinical features. DVT may be asymptomatic or present with unilateral swelling, pain, warmth, and erythema in the affected limb. Severe complications like PE are indicated by symptoms such as shortness of breath and chest pain. Diagnosis. The diagnostic approach includes using the Wells score to assess the probability of DVT, followed by D-dimer testing and venous ultrasound. A negative D-dimer can rule out DVT in patients with low pretest probability, whereas ultrasound is used for those with moderate to high probability or positive D-dimer results. Treatment. Treatment primarily involves anticoagulation to prevent clot propagation and new clot formation. Initial options include low molecular weight heparin, LMWH, unfractionated heparin, UFH, or fondaparinux, followed by longer-term anticoagulants such as vitamin K antagonists, VKAs, or direct oral anticoagulants, DOACs. In severe cases, interventions like catheter-directed thrombolysis or thrombectomy and inferior vena cava filters are considered. Prevention. Prophylactic measures are recommended for at-risk groups, including mechanical methods like graduated compression stockings and pharmacological methods such as LMWH. These measures are particularly emphasized in hospitalized or post-operative patients and long-distance travelers with additional risk factors. Complications. Chronic complications include post-thrombotic syndrome, characterized by chronic pain and swelling due to venous damage. In severe cases, venous gangrene or septic thrombophlebitis may occur. In managing DVT, it's crucial to balance the benefits of anticoagulation with the risk of bleeding, especially in patients with recurrent DVT or ongoing risk factors. This comprehensive approach aims to reduce the immediate symptoms and prevent long-term complications. Venous thromboembolism, VTE, encompassing both deep vein thrombosis, DVT, and pulmonary embolism, PE, arises due to the formation of a blood clot in the venous system, typically in the veins of the lower extremity, which can then dislodge and travel to the lungs. The development of VTE is multifactorial, largely influenced by the Virchow triad, which describes the three primary mechanisms that contribute to thrombus formation. A. Hypercoagulability. Physiological states. Certain conditions such as pregnancy, cancer, and some autoimmune diseases, e.g. antiphospholipid syndrome, naturally increase blood's tendency to clot. Genetic factors. Mutations or polymorphisms in clotting factors can predispose individuals to thrombosis. Common genetic factors include factor V Leiden mutation, prothrombin gene mutation, and deficiencies in natural anticoagulants like protein C, protein S, and antithrombin. Medications, hormone replacement therapy, HRT, and oral contraceptives increase the risk of clotting by affecting the balance of coagulation factors and inhibitors. B. Endothelial injury. Trauma or surgery. Direct damage to the vessel wall during surgeries or from trauma exposes subendothelial collagen and tissue factor, which are potent stimulators of the coagulation cascade. Medical devices. Intravascular devices like central venous catheters and pacemaker leads can irritate the veins endothelium, leading to thrombus formation. Chemical damage. Certain medications and toxins can damage the endothelium, further promoting thrombosis. See venous stasis. Immobility or reduced mobility. Prolonged bed rest, paralysis, or lengthy travel can decrease venous return, increasing the risk of clot formation due to stagnated blood flow. Varicose veins. These can impede venous flow, creating areas of turbulence and pockets of stasis, which are conducive to clot formation. Impaired heart function can lead to poor blood flow and pooling of blood, particularly in the lower extremities. High yield points. Integrated mechanisms. Often more than one element of the Virchow triad is involved in the development of VE, particularly in high-risk scenarios like major surgery, severe trauma, or during active cancer treatment. Contextual factors. The specific context and combination of factors, genetic, acquired, temporary, or persistent, determine the overall risk and guide both prophylactic and therapeutic strategies. Preventive measures. Given the multifactorial nature of VTE, preventive measures can vary widely, including pharmacologic prophylaxis, e.g. anticoagulants, mechanical methods, e.g. compression stockings, and lifestyle modifications, e.g. encouraging mobility. Understanding these mechanisms not only aids in the prevention and treatment of VTE, but also in tailoring individual care plans to effectively manage risk in susceptible individuals. Cancer, bronchial carcinoma, bronchogenic carcinoma. Overview. A. Characteristic symptoms and pathophysiology. Symptoms, often asymptomatic early on. Late-stage symptoms include cough, hemoptysis, progressive dyspnea, wheezing, chest pain, and systemic symptoms like weight loss and fever. Pathophysiology, divided into small cell lung cancer, SCLC, and non-small cell lung cancer, NSCLC, with distinct growth patterns and molecular characteristics. B. Clinical presentation and diagnosis. Presentation. Detected incidentally via imaging or presents with pulmonary or extrapulmonary symptoms, paraneoplastic syndromes, and signs of metastasis. Diagnosis. Initiated by chest CT imaging, confirmed via bronchoscopic or CT-guided biopsy. Staging includes PET-CT for assessing metastatic disease. C. Treatment, NSCLC. Depending on stage, treatments range from surgical resection, chemotherapy, radiotherapy, to targeted therapies, EGFR inhibitors, ALK inhibitors. SCLC, treatment typically involves chemotherapy and radiotherapy with consideration for prophylactic cranial irradiation. D. Prognosis, NSCLC, better prognosis compared to SCLC. Early stage disease has a significantly higher survival rate. Aggressive with poor prognosis, extensive stage survival rates are notably low. High yield points. Smoking. Smoking is the primary risk factor for lung cancer, implicated in 80 to 90% of cases. Lung adenocarcinoma, more common in non-smokers, often presents peripherally, while squamous cell carcinoma and SCLC typically present centrally. Paraneoplastic syndromes are more common with SCLC. These include SIADH and Lambert-Eaton syndrome. Differential diagnosis table. Condition, likely features, typical location, primary lung cancer, irregular margins, larger size, central or peripheral, lung metastases, multiple nodules, varied. Infectious granulomas, well-defined, calcified, varied. Benign lung tumors, popcorn calcifications, well-circumscribed, peripheral. This summary provides a comprehensive, high-yield overview to aid in preparation for medical licensing exams and clinical application. Differential diagnosis. Cough, a common symptom encountered in clinical practice, can be acute or chronic and is often a diagnostic challenge due to its broad differential. Here is a concise guide. A. Infectious causes. Upper respiratory infections or eyes. Common cold, sinusitis, pharyngitis. Pneumonia. Bacterial, viral, fungal infections. Tuberculosis, particularly in high-risk populations or endemic areas. Pertussis, especially in unvaccinated populations. B. Non-infectious causes, asthma, often accompanied by wheezing and dyspnea. Chronic obstructive pulmonary disease, COPD, especially in smokers or those with a history of chronic respiratory symptoms. Gastroesophageal reflux disease, GERD, cough due to acid reflux, especially postprandial or nocturnal. Chronic bronchitis, persistent cough with sputum production for at least 3 months in 2 consecutive years. C. Environmental exposure-related, smoking, both active and passive smoking, occupational exposures, dust, chemicals, fumes, etc. Pollution, air pollutants can trigger or exacerbate cough. D. Medication-induced, ACE inhibitors, cause dry cough in a significant percentage of patients. Beta blockers can exacerbate respiratory conditions like asthma or COPD. E. Cardiac causes, heart failure, cough due to pulmonary congestion, often accompanied by dyspnea and orthopnea. F. Miscellaneous, foreign body aspiration, especially in children. Pulmonary embolism, especially if associated with chest pain and dyspnea. Lung cancer, consider especially in smokers or those with hemoptysis and weight loss. Postnasal drip, upper airway cough syndrome, cough associated with the sensation of liquid in the back of the throat. Psychogenic cough, consider after excluding other causes, often in the absence of night symptoms. G. High-yield diagnostic evaluation, history and physical examination. Focus on duration, associated symptoms, exposure history, and medication use. Chest X-ray, initial imaging to evaluate for infections, chronic lung disease, or malignancy. Pulmonary function tests to assess for asthma or COPD. CT scan of the chest for detailed lung and mediastinal imaging, especially if suspecting cancer or complicated pneumonia. Laboratory tests, complete blood count, sputum analysis, and specific tests like ACE levels if sarcoidosis is suspected. This comprehensive approach ensures that the underlying cause of cough is methodically evaluated and appropriately managed. Hemoptysis overview. A. Characteristic symptoms and pathophysiology. Definition. Hemoptysis is the expectoration of blood originating from the lower respiratory tract. It may vary from small specks of blood to large volumes that can be life-threatening. Pathophysiology. Hemoptysis often arises from bleeding in the bronchial arteries, 90% of cases, but may also involve pulmonary and systemic arteries. B. Clinical presentation and diagnosis. Presentation. Symptoms range from mild blood-streaked sputum to massive hemoptysis with respiratory distress. The condition prompts urgent evaluation to determine the severity and underlying cause. Diagnosis. Initial assessment with a portable chest X-ray, CXR, to detect possible causes. Further diagnostic steps include CT, teeth, chest ultrasound, and bronchoscopy, especially in cases of massive or unexplained hemoptysis. C. Treatment. General approach. Management begins with stabilization, including airway protection and respiratory support. Treatment then focuses on identifying and addressing the underlying cause. Specific therapies. For massive hemoptysis, options include bronchial artery embolization, BAE, or surgery. Tranexamic acid may be used for symptomatic relief in non-massive cases. D. Prognosis. General outlook. Prognosis depends on the underlying cause and the amount of blood loss. Massive hemoptysis has a higher risk of mortality compared to non-massive cases. Severity assessment differentiates between massive and non-massive hemoptysis based on volume, speed of blood loss, and associated respiratory or hemodynamic compromise. High yield points. Common causes include infections like tuberculosis and pneumonia, neoplasms such as bronchogenic carcinoma, and vascular disorders like pulmonary embolism or vasculitis. Initial management. Even a small amount of hemoptysis is treated as potentially life-threatening until proven otherwise. ABC survey and immediate imaging are crucial. Massive hemoptysis. Defined variably, often involving significant blood loss, e.g. 100 milliliters per hour, requiring urgent and aggressive management to stabilize the patient. Differential diagnosis table. Condition, common features. Diagnostic approach. For pulmonary infections, fever, localized infiltrates on CXR, sputum culture, antibiotics, history of smoking, weight loss, CT scan, bronchoscopy with biopsy, tuberculosis, chronic cough, night sweats, sputum smear for acid-fast bacilli, CXR, pulmonary embolism, sudden onset dyspnea, chest pain, CT pulmonary angiography, vasculitis, systemic symptoms, multi-organ involvement, autoantibodies, renal function tests. This summary provides a structured approach to the evaluation and management of hemoptysis, tailored for quick reference in clinical settings and exam preparation. Hemoptysis, the expectoration of blood from the lower respiratory tract, can be triggered by a variety of pulmonary and cardiac conditions. Here are the major causes grouped by their general categories. A. Infectious causes. 1. Tuberculosis, often the leading cause of hemoptysis worldwide, particularly in regions where the disease is endemic. 2. Bacterial pneumonia, especially when it leads to lung abscess formation. 3. Bronchiectasis. Chronic infection and inflammation can erode blood vessels, causing bleeding. 4. Aspergillosis, fungal infection that can lead to aspergilloma, a fungal ball that causes bleeding. 5. Lung abscess, pus-filled cavities in the lung due to infection can erode into blood vessels and cause bleeding. B. Neoplastic causes. 1. Lung cancer, particularly bronchogenic carcinoma, can erode into airways and blood vessels. 2. Metastatic cancer. Tumors from other parts of the body that have spread to the lungs can cause bleeding. 3. Bronchial adenoma. Though often benign, these tumors can cause significant bleeding. C. Cardiovascular causes. 1. Mitral stenosis. Increases pressure in the left atrium and pulmonary veins, potentially leading to rupture of small vessels. 2. Congestive heart failure. Elevated pulmonary capillary pressure can lead to pulmonary edema and hemoptysis. 3. Pulmonary embolism. Blood clots in the pulmonary arteries can cause infarction and subsequent bleeding. 4. Pulmonary artery aneurysm. Rare but can result in significant hemoptysis if rupture occurs. D. Vascular disorders. 1. Vasculitis, such as in granulomatosis with polyangiitis, GPA, formerly known as Wegener's granulomatosis, which causes inflammation and necrosis of blood vessels. 2. Goodpasture syndrome, an autoimmune disease that attacks the lungs and kidneys, leading to bleeding within the lungs. 3. Hereditary hemorrhagic telangiectasia, a genetic disorder causing fragile blood vessels. E. Other causes. 1. Anticoagulant use. Medications like warfarin or heparin can increase the risk of bleeding from any small source within the lungs. 2. Trauma, such as a chest injury, can tear blood vessels within the lungs. 3. Foreign body aspiration, especially in children, can cause irritation and bleeding. 4. Idiopathic pulmonary hemosiderosis, a rare condition involving recurrent bleeding into the lungs. F. Miscellaneous causes. 1. Coagulopathies, conditions that impair blood clotting can lead to spontaneous bleeding from the lungs. 2. Endometriosis. Rarely, endometrial tissue can attach to lung tissue, thoracic endometriosis, causing cyclical hemoptysis. Diagnostic considerations. Imaging. Chest X-ray, CT scans, and sometimes bronchoscopy are essential tools for diagnosing the cause of hemoptysis. Laboratory tests. Blood tests, including coagulation profiles and autoimmune panels, can help diagnose systemic causes like vasculitis or coagulopathies. Understanding these causes is crucial for targeting treatment and managing hemoptysis effectively in clinical practice. Solitary pulmonary nodule, differential diagnosis. A solitary pulmonary nodule, SPN, is a single, well-defined lesion in the lung that is completely surrounded by lung tissue and not associated with any other lung abnormalities. The differential diagnosis for an SPN includes a wide range of benign and malignant conditions. A. Neoplastic causes. 1. Primary lung cancer, particularly adenocarcinoma, which often presents as a peripheral nodule. 2. Bronchogenic carcinoma can present as a solitary lesion, especially in its early stages. 3. Carcinoid tumor, typically slow-growing and may present as a solitary nodule. 4. Hamartoma, the most common benign tumor of the lung, often containing fat and calcifications. B. Infectious causes. 1. Granuloma, often due to tuberculosis or fungal infections such as histoplasmosis, which can calcify over time. 2. Bacterial pneumonia can leave a solitary residual nodule post-infection. C. Inflammatory causes. 1. Rheumatoid nodule, associated with rheumatoid arthritis and typically found in the periphery of the lungs. 2. Wegener's granulomatosis, now known as granulomatosis with polyangiitis, can present with solitary or multiple nodules with or without cavitation. D. Vascular causes. 1. Arteriovenous malformation, a rare cause but can appear as a solitary nodule on imaging. E. Miscellaneous causes. 1. Pulmonary infarct. Necrosis of lung tissue due to pulmonary embolism can appear as a solitary nodule, typically wedge-shaped. 2. Round pneumonia, typically seen in children, can appear as a rounded solitary lesion mimicking a nodule. 3. Localized fibrosis can manifest as a solitary nodule, often due to prior inflammation or injury. F. Benign lesions. 1. Intrapulmonary lymph node can appear as a well-defined nodule on imaging. 2. Pulmonary sequestration, a rare congenital malformation that can present as a non-functioning mass of lung tissue. G. Metastasis. 1. Extrapulmonary cancers, such as breast, colon, or renal cancer, can metastasize to the lungs, appearing as a solitary nodule. Diagnostic approach. 1. Imaging studies. Initial evaluation with chest X-ray, followed by high-resolution CT scan to assess the size, shape, edge characteristics, and calcification patterns of the SPN. 2. PET scan can help differentiate benign from malignant nodules based on metabolic activity. 3. Biopsy, recommended if the nodule is suspicious for malignancy on imaging or based on patient's risk factors, e.g. history of smoking, age, prior cancer. 4. Follow-up imaging. For nodules that are indeterminate, serial imaging over a period of up to 2 years may be recommended to monitor for changes in size or appearance. Understanding the wide array of potential diagnoses is crucial for guiding the appropriate management of an SPN and determining whether further investigation or intervention is warranted. Cough. Overview and management. A. Characteristic symptoms and pathophysiology. Definition. Cough is a reflex or voluntary action aimed at clearing the airways of irritants, secretions, or foreign objects. Mechanisms. Involves a cough reflex arc that starts with the irritation of cough receptors located throughout the respiratory tract, leading to a complex reflex involving inspiration, closure, and sudden opening of the vocal cords, and rapid expulsion of air. B. Classification. By duration, coughs are categorized as acute 3 weeks, subacute 3 to 8 weeks, and chronic 8 weeks. By type, productive with sputum and dry, non-productive. C. Etiology. Acute cough, most commonly caused by upper respiratory tract infections, URTIs, pneumonia, and exacerbations of chronic conditions like asthma and COPD. Subacute cough often follows a URTI, post-infectious cough, and can be due to conditions like pertussis or upper airway cough syndrome, UACS. Chronic cough, typically due to UACS, asthma, GERD, non-asthmatic eosinophilic bronchitis, NAEB, and side effects from medications such as ACE inhibitors. D. Diagnostic approach. Initial evaluation. Focus on medical history and physical examination to identify red flags such as dyspnea, hemoptysis, fever, or weight loss that may indicate a serious underlying condition. Investigations may include chest X-ray, CT scan, spirometry, and specific tests for conditions like GERD, asthma, or infections, depending on the duration and characteristics of the cough. E. Treatment. Based on etiology, aimed at treating the underlying cause, whether it's an infection, chronic disease, exacerbation, or irritation from GERD. Symptomatic relief may involve cough suppressants, expectorants, or mucolytics to manage the symptoms while the primary cause is addressed. High yield points. Acute cough management, often self-limiting. Treatment is usually supportive unless bacterial infection is suspected. Chronic cough management requires more extensive diagnostic testing to determine the underlying cause. Treatment may involve multiple therapies aimed at different potential triggers. Red flags include smoking history, significant weight loss, persistent or severe symptoms, which may suggest more serious conditions like lung cancer or tuberculosis. Differential diagnosis table. Condition key features common in fear symptoms. URTI, cough, fever, nasal congestion, acute cough. Asthma, wheezing, dyspnea, reversible airflow obstruction, chronic cough. GERD, heartburn, cough worse at night, chronic cough, cancer, weight loss, hemoptysis, history of smoking, chronic cough. Pertussis, paroxysmal cough, inspiratory whoop, posttussive vomiting, subacute cough. This summary provides a structured framework for understanding the pathophysiology, diagnosis, and management of coughs of varying durations and types, essential for clinical practice and educational purposes. Necessary for diagnosing specific inflammatory or malignant conditions, particularly in complicated This analysis helps guide the clinical management of various diseases affecting the pleural, peritoneal, and central nervous system environments. Diagnosis, confirmed by complete colonoscopy with biopsy. Initial workup includes digital rectal examination and possibly flexible sigmoidoscopy in younger patients without red flags. Staging, essential for management, involves imaging studies such as CT scans of the abdomen, pelvis, and chest to assess for metastasis. C. Treatment, surgical resection, primary treatment modality with intent to cure, involving regional lymph node dissection and potentially resection of metastases. Chemotherapy, common regimens include FOLFOX, FOLFIRI, and CAPOX, especially for advanced stages. Radiation therapy, used mainly in rectal cancer, less commonly in colon cancer except for palliative care. restore circulatory volume, followed by the correction of dehydration. Fluid replacement includes both enteral, oral rehydration solutions and intravenous methods, depending on the severity and patient's ability to tolerate oral intake. Ongoing management includes maintenance of fluid balance, correction of electrolyte imbalances, and addressing the underlying causes of fluid loss. Deprognosis. Timely and effective management typically results in full recovery. However, Sepsis is a severe, life-threatening response to an infection that leads to tissue and organ damage through a dysregulated immune system response, potentially progressing to multiple organ dysfunction syndrome, MODS, and septic shock. Key aspects of sepsis include A. Characteristic symptoms and pathophysiology. Hyperinflammatory response, triggered by local activation of inflammatory mediators, leading to generalized endothelial disruption, capillary leak, and edema. Organ dysfunction, resulting from decreased oxygen utilization, tissue ischemia, and widespread cellular injury. Often presents as multisystem organ failure. Coagulation activation, disseminated intravascular coagulation, DIC, due to excessive activation of the coagulation cascade. B. Clinical presentation and diagnosis. General features, fever, chills, tachycardia, tachypnea, and generalized edema. Organ-specific symptoms include CNS impairment, altered mental status, cardiovascular failure, hypotension, liver failure, jaundice, and kidney failure, oliguria. Septic shock features. Persistent hypotension requiring vasopressors to maintain MAP towards 65 mm Hg, altered skin perfusion, and signs of the primary infection site. Diagnostic criteria based on SIRS criteria, SOFA score, and evidence of persistent lactic acidosis or hypotension. C. Treatment. Immediate interventions include rapid IV fluid resuscitation, administration of broad-spectrum antibiotics within 1 hour for shock, and vasopressors if needed. Hour 1 bundle. Critical steps include obtaining serum lactate, drawing blood cultures, beginning rapid IV fluid bolus, and using vasopressors and antibiotics. Ongoing management, continuous hemodynamic reassessment, support of organ functions, and specific treatment based on the source of infection. D. Prognosis. Early identification and treatment are crucial for improving survival rates. The prognosis worsens significantly with delays in treatment and the onset of septic shock and multiple organ dysfunction. Differential diagnosis. Conditions that mimic sepsis include various forms of shock, hypovolemic, cardiogenic, acute pancreatitis, anaphylaxis, and endocrine emergencies like thyroid storm and adrenal crisis. High yield points, early detection, rapid identification and treatment initiation are pivotal. Fluid and hemodynamic management, key to preventing progression to shock. Antibiotic timing, critical within the first hour if septic shock is suspected. Understanding and managing sepsis effectively requires a thorough approach tailored to the rapid progression of the disease, emphasizing the urgency of intervention to mitigate the high mortality associated with this condition. Systemic inflammatory response syndrome, SIRS, is a clinical syndrome characterized by widespread inflammation in organs remote from the initial insult, which can be triggered by an infectious or non-infectious event. Here are the key points about its definition and causes. A. Definition of SIRS. SIRS is diagnosed when 2 or more of the following criteria are met, indicating a systemic response to a variety of severe clinical insults. Temperature. Body temperature greater than 38 degrees Celsius, 100.4 degrees Fahrenheit, or less than 36 degrees, 96.8 degrees Fahrenheit. Heart rate greater than 90 beats per minute. Respiratory rate greater than 20 breaths per minute, or arterial carbon dioxide tension, PaCO2 less than 32 millimeter grams. White blood cell count. elevated 12,000 myelella, depressed 4,000 kKs, or the presence of greater than 10% immature neutrophils, band forms. Causes of SIRS. SIRS can be triggered by a wide array of conditions that lead to an overwhelming inflammatory state. These include infectious causes, bacterial infections, often the most common infectious cause of SIRS, viral infections such as influenza or severe acute respiratory syndrome, SARS, fungal and parasitic infections can also trigger a SIRS response. Non-infectious causes, trauma, such as burns, fractures, or crush injuries, pancreatitis, particularly when severe, can lead to SIRS. Ischemic events, such as myocardial infarction or severe hemorrhage. Autoimmune disorders, diseases like rheumatoid arthritis or systemic lupus erythematosus, can initiate a SIRS-like response. Severe allergic reactions, such as anaphylaxis. Others, such as drug reactions or chemical exposures. High yield points. Broad spectrum of triggers. Both infectious and non-infectious causes can initiate SIRS, making the identification of the underlying cause essential for appropriate management. Vital signs monitoring. Vital signs are key indicators in diagnosing SIRS. They help in assessing the severity and progression of the syndrome. Early intervention. Timely recognition and management of SIRS can prevent progression to more severe conditions such as sepsis or septic shock. Understanding the triggers and criteria for SIRS is crucial for early identification and appropriate management, which can significantly affect outcomes, particularly in critically ill patients. Polycystic ovary syndrome, PCOS, also known as Stein-Leventhal syndrome or hyperandrogenic anovulation, is a prevalent endocrine disorder affecting 6 to 12% of women in their reproductive years. Here are the key aspects of PCOS. A. Characteristics, symptoms, and pathophysiology. Hyperandrogenism, manifested as hirsutism, acne, and occasionally virilization. Ovarian dysfunction, oligoovulation or anovulation, typically leading to infertility. Polycystic ovaries, visible on ultrasound, characterized by multiple cystic follicles. Insulin resistance, often associated with obesity, contributing to increased androgen production and metabolic complications. B. Clinical presentation and diagnosis. Menstrual irregularities, such as amenorrhea or oligomenorrhea. Metabolic syndrome, increased risks of obesity, type 2 diabetes, and cardiovascular diseases. Diagnostic criteria, Rotterdam. At least 2 of the following are needed for diagnosis: oligoovulation, anovulation, hyperandrogenism, and polycystic ovaries on ultrasound. C. Treatment, non-reproductive goals. Combined oral contraceptives, COCs, are used to manage menstrual irregularities and mitigate hyperandrogenism. Reproductive goals. Treatments like letrozole or clomiphene are used for ovulation induction to aid conception. Lifestyle modifications, emphasized for weight management and reduction of cardiovascular risks. D. Prognosis. While PCOS is a chronic condition, effective management can mitigate symptoms and reduce the risk of long-term complications. High yield points. Comprehensive management. Address both reproductive and metabolic aspects. Early diagnosis and lifestyle intervention, critical for managing long-term risks and improving quality of life. Regular screening, essential for associated comorbidities such as diabetes, cardiovascular diseases, and endometrial cancer. Understanding and managing PCOS requires a multifaceted approach, focusing on both symptom control and the prevention of associated health issues. Hirsutism and virilization are clinical conditions associated with excessive male pattern hair growth and the development of other male characteristics in women, respectively. Here are detailed insights into these conditions. A. Characteristic symptoms and pathophysiology. Hirsutism. Definition: excessive hair growth in women in areas where hair is typically minimal or absent, such as the face, chest, and back. Pathophysiology: life often results from elevated androgen levels or increased skin sensitivity to androgens. Commonly associated with conditions like polycystic ovary syndrome, PCOS, which lead to increased production of androgens by the ovaries and adrenal glands. Virilization. Definition: the appearance of secondary male sexual characteristics in a woman, such as a deepened voice, increased muscle mass, and clitoromegaly. Pathophysiology indicates a more severe state of hyperandrogenism than hirsutism. It is often caused by conditions that significantly elevate androgen levels, such as androgen-secreting tumors or severe adrenal hyperplasia. B. Clinical presentation and diagnosis. Hirsutism, evaluated using the Ferriman-Galway scoring system, which quantifies hair growth in areas typical of male patterns. Virilization includes symptoms like male pattern baldness, clitoral enlargement, increased muscle mass, and changes in body fat distribution. Diagnostic approach includes thorough history taking and clinical examination, hormone level tests, e.g. testosterone, DHEAs, and imaging studies to identify potential sources of excessive androgen production, e.g. ovarian or adrenal tumors. Censure C. Treatment. Hirsutism. Medications. Oral contraceptives to reduce androgen production. Anti-androgens such as spironolactone, which blocks androgen receptors, and 5-alpha reductase inhibitors like finasteride. Cosmetic treatments. Methods like electrolysis and laser hair removal can be effective for managing unwanted hair. Virilization. Identifying and addressing the underlying cause, essential for treatment, particularly if caused by a tumor or other pathological conditions. Hormonal therapy may include glucocorticoids if adrenal hyperfunction is identified.
D.
Prognosis. Hirsutism. Generally manageable with treatment but may be chronic, requiring ongoing management. Virilization. Prognosis depends on the underlying cause. Early detection and treatment are crucial for favorable outcomes. High yield points. Early and accurate diagnosis, crucial for effective treatment, especially to rule out serious underlying conditions. Management strategy should be tailored to the individual, considering the severity and underlying cause of the symptoms. Regular follow-up to adjust treatment as needed and monitor for side effects, especially with pharmacologic therapies. Hirsutism and virilization not only impact physical health, but can also significantly affect psychological well-being, making empathetic and comprehensive care essential. heart failure,